Good evening, everyone. So this week we will start with the sclerosing reaction pattern. This is the part 7 or the seventh reaction pattern in our dermatopathology series. Now, in my opinion, sclerosing reaction pattern is one of the toughest reaction patterns because it constitutes of a lot of different lot of different disorders that you see in biopsy. Clinically, it's very or comparatively easier to diagnose sclerosing dermatosis because you can actually feel the induration, you can actually look at the atrophy, and you can very well guess whether it is epidermal atrophy or dermal atrophy. But when we go into biopsying these lesions and looking at the histopathological structures, we need to have certain criteria of segregating them or certain criteria of dividing them into separate groups so that we can easily have a good understanding of what exactly is happening at the biopsy level. Okay, so this week we'll try to understand multiple disorders which present with sclerosing reaction pattern or sclerosis on biopsy. So without much further ado, let's start our discussion on the sclerosing reaction pattern. Now in sclerosing reaction pattern, the major action is in the dermis. So everything is happening in the dermis. The epidermis is secondarily affected. It might be atrophied, it might be, hyperkeratotic, or it could be just parakeratotic epidermis. But remember, the major action is happening at the level of dermis, okay? Clinically, you see the lesions as fibrosis or atrophy, which can include epidermis with or without dermis, but there will be dermal changes clinically. Hypertrophy, induration, that is some kind of tightness or infiltrated look. Deposition, that we clinically label as an infiltrated plaque. So something is deposited. We can actually touch the lesion and feel that something is deposited in the dermis. And color change. Okay, so if you have changes in the dermis and the epidermis, the texture and color of the plaque would change. Okay, that's how sclerosing reaction pattern presents clinically. So let's go forward. So we'll start a discussion on sclerosing reaction pattern. Now remember, in sclerosing reaction pattern, if this is your biopsy, this is the epidermis and this is the dermoepidermal junction. Remember what I said, that the major action happens in the dermis, okay? And in the dermis, you have two major fibers. You have the collagen fibers and then you have the elastic fibers. And elastic fibers are made up of elastin proteins. Okay, collagen fibers are made up of collagen proteins. Proteins. Okay. So remember that collagen is the major fiber. About 70% of the dermis is made up of collagen, and rest of the other structural components, including elastin. So any disorders that presents as a sclerosing reaction pattern will have a problem in collagen or elastin, and most of the time it is both of these that are affected, but majorly collagen becomes collagenous disorders, while majorly elastic will become disorders of elastic fibers. Okay, remember that this is a very balanced environment. The dermis is a very balanced environment, and any problems in the collagen will lead to problems in the elastic and other tissues. Okay, so when the disorder has major problems with the collagen fibers, we label it as collagenous disorders, and if the major problem lies with the elastic fibers, we label them as disorders of elastin tissue. Okay, with that and background understanding, let's move forward. Now, in classification of sclerosing disorders, we classify them as either collagenous disorders, which are the major group of disorders, the elastin, in which the disorders are in the elastin or the elastic fibers, mucin, in which there is mucinous deposition in the dermis, and any other cutaneous deposits. For example, calcium deposits that we see in calciphylaxis, okay, or let's say steroid deposits in multiple intralesional injections, intradermal injections. So this lecture, we will focus more on collagen and elastin. We will not be covering mucin because that actually requires a separate video altogether. And I would like to cover histopathology of mucinous disorders while discussing mucinous disorders. In fact, mucinous disorders individually is a very tough topic to understand, in my opinion. It may be easier to others, but for me it is a bit tough. So I would like to develop a proper understanding and then move when we will be discussing mucinous disorders. And I will not be discussing other cutaneous deposits because there are so many of them and so varied. So you can have all sorts of deposition in the dermis, which can present as a sclerosing reaction pattern. So we will focus majorly on collagenous disorders and disorders of elastin. Okay, let's move forward. So the lecture is essentially divided into two parts. The first part is collagenous disorders, and the second part is disorders of the elastic fibers. Okay. Now what I have done is I have utilized the classification method that Weedon uses. So Weedon's histopathology has a certain way of classifying sclerosing reaction pattern, and I've used the same one so that for me it was very easier to understand the classification of sclerosing disorders when I followed the Weedon's classification, and that's not the name, that is just the classification the Weedon's book uses, and that is why I'll be utilizing the same classification pattern. And let's start with the first part of the series, collagenous disorders. Let's study a bit about collagen. Collagen, as I've said, is a major protein. About 70% of the skin's dry weight is made up of collagen. So this could be a good MCQ question. Okay, about 70% of the dry weight is collagen. Majorly, type 1, 2, 3 are the individual fibers of collagen. So these are the fibers of collagen. Okay, so alpha, you have beta, you have gamma fibers. Okay, and these three fibers together coil around each other to form a triple helical structure. Okay, a triple helical structure. So can you see that these three fibers are coiled together to form a helix? So it's a triple helical structure. The major amino acid is glycine. About one-third amino acids in the chain of amino acids that form collagen. The one-third amino acids are glycine. The rest are majorly proline and hydroxyproline, which roughly constitutes about 20% of the amino acids. Clear? Now, when a collagen fiber is formed, for example, this is a collagen fiber, okay? It attaches itself to other collagen fibers longitudinally and laterally. Now, what do we mean by that? It means that, let's say these are the collagen fibers, okay? And it will attach laterally like this from the sides and also longitudinally, that is from the ends. And because of these kind of attachment to other collagen fibers, it provides structure to the dermis. So the major function of collagen is to provide structure to the dermis. Structure or solidity, okay, to give a certain strength to the dermis. The oxidation of lysyl and hydroxyl lysine residues. Now remember, there are multiple amino acids in the collagen molecule, and some of them which are lysyl and hydroxylysyl, residues, they have stable cross links. That means they link with each other. So these all links that we talked about, the lateral links and the ends link, these are between different amino acids. And if those amino acids are lysyl or hydroxylysine, these also link together, and these links are not that strong. But what is the function of these links is to provide bendability to the dermis. And that is why your skin is flexible. Why it is flexible? Because it has this solidity, the structure coming from majority from the collagen fibers and a little bit of tensile strength. What is tensile strength? That is when you put a shear pressure or a horizontal pressure on the skin just moves a bit, but it doesn't get sheared off. So that is the tensile strength. Majority of the tensile strength comes from the elastic fibers, but collagen fibers do provide a bit of tensile strength by virtue of having lysyl and hydroxylysine amino acids. Let's move forward. So now we'll start classifying collagenous disorders so that we can discuss them separately. Okay. So you have collagen disorders. The first is scleroderma, in which there is thickening of the skin. Okay. Then we have sclerodermoid disorders. That means disorders which look like scleroderma, but not exactly scleroderma. Then you have other hypertrophic collagenoses, atrophic collagenosis, in which you have atrophy instead of hypertrophy, perforating collagenoses, in which you have perforating disorders, variable collagen changes, that means minute changes happening here and there, and syndromes of premature aging. So predominantly we'll cover these. let me draw or attempt to draw a straight line. Okay, so we'll cover these. The variable collagen changes and syndrome of premature aging are actually beyond the scope of this lecture. It's not that important, but we'll have to cover scleroderma, sclerodermoid disorders, atrophic, perforating collagenoses a bit in detail. Let's move forward and we will start our discussion first with scleroderma. Now, in scleroderma, what exactly happens is that there's thickening, there's high induration of skin, and you can actually feel because whenever, let's say, the prototype disorder of scleroderma is morphea. So imagine yourself just moving a morphea plaque underneath your fingers, and you will understand what I mean when I say that it is indurated, thickened skin. So let's move forward and discuss scleroderma. Now, scleroderma can be divided into number one, localized scleroderma, in which you have morphea along with its variants, or linear scleroderma. Okay. In systemic scleroderma, you have diffuse systemic sclerosis, or the limited form of systemic sclerosis, which is there on the fingers majorly, or the crest syndrome. So if you know the full form of crest, mention that in the comments. I will not go into that. Scleroderma is also seen in mixed connective tissue disease, Eosinophillic Fascitis, and Atrophoderma of Cassini and Pyrenees. So we will discuss each of these disorders very quickly, one slide each, to find out what exactly is happening in the pathology of scleroderma to show the sclerosing reaction pattern. Okay, let's move forward. Let's start with the histology of morphea. In morphea, the epidermis may be normal or it can be atrophic. And that is majorly, most commonly atrophic, a lot more than being a hypertrophic. Okay. But again, remember in sclerosing reaction pattern, the action lies in the dermis. So in dermis, there is thickened, broad sclerotic collagen bundles extending to the subcutis and periadnexally. Now remember, if you have gone through a video on histology of dermis, the collagen fibers are eosinophilic and they're thin, they're fibrillar, they're like fibers. That is what they are, collagen fibers. But whenever they're going to become scarred or they're going to become pathologically not able to properly maintain their function and structure, they will become broad, thickened. Okay, so broad sclerotic collagen bundles. You will see that they are equally stained, paler, not exactly bright pink that you usually see in a normal biopsy and it is very essential. Okay, I'm just going a bit off topic, but it becomes very essential that if you're looking at a biopsy in which dermis is normal, appreciate how a normal collagen looks like, because if you know what the normal structure is, you can easily find out problems when there are disorders. Okay, later as the disease progresses, the collagen becomes less homogenized. Again, I told you that a pathological collagen is uniformly stained, pale stained, broad, thickened bundles. Okay, there's increase in fibroblasts and mucopolysaccharides, and rarely mucin can be increased. Remember, mucin cannot be seen in H&E staining. You require special stains like Alcian blue. Okay, Alcian blue. But if you see in H&E and there are spaces in between the collagen fibers, most likely it could be because of mucin. Because mucin gets washed away in H&E, leaving behind empty spaces. There is atrophy of the adnexa. Adnexa are the other structures like follicles, sebaceous glands, sweat glands. Okay. You have higher up eccrine glands. Now, what exactly is happening in morphea when the dermis gets, shrunken up, shriveled, or tightened? It pulls the adnexa up. So imagine if my entire hand is the dermis. Let me just put it here. Yeah, entire hand is the dermis, and this is the sweat gland. Or okay, this is the structure, the pen structure. It will pull it up. So that is known as pulled up eccrine glands or pulled up adnexa, and you see eccrine glands at a higher than normal level. Okay, thicker erector pylori, thickened vascular walls with narrower lumen. So the vessel walls become thicker and the lumen narrows. What we describe as square cut biopsy. What do we mean by square cut biopsy? Now, what exactly happens is that whenever you biopsy a tissue, after the tissue is removed from the body, the tissue shrinks up, okay, and gets fixed in the formalin. But since you are dealing with a sclerosing disorder, a disorder that actually toughens up the dermis, it thickens the dermis, the biopsy remains like a square shape, like this, okay? So it's more of a rhombus, but you will get my point. Okay. So you can see clear 90-degree edges, perpendicular. You will see clear 90-degree corners, sharp corners. And in fact, you can clearly make out that here the dermis ends and here the dermis begins. So this whole is dermis. In a normal biopsy, you will see a wavy dermoepidermal junction and a little bit of subcutis going inside the dermis. But in sclerosing disorders, you see a square cut biopsy, typically exemplified by morphea. The inflammatory infiltrate consists of lymphocytes, which are CD4, CD8 positive, macrophages, and plasma cells. And these are seen at the border of the biopsy, at the edges. Now, when a dermis undergoes sclerosis, tightening, the inflammatory cells might not be that prominent because there is no space for them to stay. So they are found majorly at the edges where the inflammatory activity is ongoing. So it's a good idea to take a biopsy from the edge of the morphea, not from the center of the morphea, or you will see only sclerosis, no inflammatory activity. Okay, other cells you can see are natural killer cells and Langerhans cells. Okay. So look at this biopsy from the morphea lesion. Okay, let me just change the color. And in fact, you can easily see that there is this area in which the collagen bundles are thickened. Can you see? Can you compare this area with the top? So here is the normal collagen, while here is the morphea. Okay, so I'll just remove this and you'll be easily able to appreciate the separate collagen and normal collagen. Okay. So this is how a square cut biopsy with homogenized swollen collagen bundles, you can actually see that this the thickness of collagen here. Look how thick it is. Okay. So you can see these are swollen collagen bundles. Normally they would have been, thinner and fibrillar like this, but they are swollen and homogenized, nearly same pale in color as compared to tightly packed rows of collagen. Let's move forward. In diffuse scleroderma, the features are same as morphea, but the inflammatory changes are less marked. There's a less inflammation. There is subtle collagen deposition, mild papillary dermal edema, but the prominent changes are the vessel changes. You have severe intimal fibrosis in small arteries and arterioles. So what exactly happens is, if this is the artery and there is sclerosis of the artery walls, the lumen will get narrower and the intima will show proliferation and fibrosis. Fibrosis. So the major action lies around the vessel. So perivascular inflammatory infiltrate, but milder in quantity, with severe intimal fibrosis and narrowing of the lumen. Okay. There is minimal papillary dermal fibrosis. So majorly the vessels are affected, not the dermis. Other things that you can see are calcification, increased mast cells, and pigmentary anomalies. We know that in scleroderma, you have the salt and pepper dyspigmentation, and if the biopsy is taken from there, you will see pigmentary anomalies or difference in pigmentation, but that is a very subjective finding on a biopsy. You need a normal skin to compare, to say any kind of loss of melanocytes. Okay, let's move forward. So in diffuse scleroderma, here also you can easily appreciate, let me just change the color. You can easily appreciate the thick collagen bundles, isn't it? Uniformly stained, highly eosinophilic, thick collagen bundles. Okay. And if you look at a vessel, if you go deeper and look at the vessel, you will see that the intima is thickened and lumen is narrow. Okay. Usually you don't find this big artery or arteriole in the subcutis. In the subcutis, you will have small arterioles. But here, because of thickening, it looks so big. Okay. And you can actually see the lumen is also smaller. So thick collagen bundles with minimal inflammation, see it is already fully, bland. There's no inflammatory infiltrate, and there's lumen narrowing with intimal fibrosis. Let's move forward. The third disorder is known as eosinophilic fasciitis. The other name for that is Schulman's syndrome. There is sudden onset of symmetrical induration of skin and subcutaneous tissue of the limbs. So it is sudden onset. And if anything is happening acutely or suddenly, the inflammatory infiltrate would be there, isn't it? So in morphea and systemic sclerosis, the inflammation has gone, leaving behind sclerosis. Okay. But in eosinophilic fasciitis, because of acute onset, you see an inflammatory lesion. Okay. And because of an inflammatory lesion, you will see inflammatory cells in the biopsy. So the earliest changes includes edema and infiltration of the interlobular fibrous septa of the subcutis and deep fascia. So here what we can understand is that the action is below, okay, below the dermis. The inflammation and edema is at the subcutis level along with the sclerosis of deep dermis. The cells include lymphocyte, histiocytes, plasma cells, and eosinophil. That is why it is eosinophilic fasciitis. And the collection could be focal to a prominent collection. There is striking fibrosis and hyalinization of the collagen along with appendageal atrophy. Now understand that when collagen gets thickened and fibrosed, the appendages would get suffocated, they would get crushed, and that is why you have appendageal atrophy. Okay. Remember that dermis is a balanced tissue. Everything remains in balance. If one tissue or one part of tissue is not properly functioning, like the collagen and the fibroblast, you will have problems in other tissues, and that is why subsequently all the appendages gets atrophied. Let's move forward. So look at this picture. This I've taken from Weedon's skin pathology. And here you can actually appreciate this inflammatory. This is the subcutis. Okay. It's upside down slide. Okay. The subcutis and dermis. And you can see that the junction of dermis and subcutis, there is an inflammatory infiltrate. This whole area is infiltrate or filled with inflammatory cells. And if you can make out, you can actually find few of giant cells. So these are easily visible. And if you look at a lot of red cells, red colored cells, and these are nothing but eosinophils. Okay, so let me just get rid of all the markers, and then you'll be able to appreciate this red dot cells, which are eosinophils. Okay, same, this picture I've taken from McKee's high yield pathology, high yield histology of the skin. And here also you can see the junction between dermis and subcutis. This is subcutis. Dermis. So dermis and subcutis, you have the inflammatory infiltrate. And if you look closely or if you look at higher magnification, you'll be able to see eosinophils inside the inflammatory infiltrate. So in that, in eosinophilic fasciitis, you have facial connective tissue thickening along with lymphocytes, plasma cells, histiocytes. But remember, the predominant or the major player here is the eosinophils. Let's move forward. The fourth disorder that we'll consider now is Atrophoderma. In Atrophoderma, the dermis shows atrophy as compared to normal dermis. So you need a normal dermis comparison to see that atrophy has happened. There is edematous and slightly homogeneous collagen. Now remember these words: bulky, thickened, homogenized, paler. That is the thing that differentiates pathological collagen from normal collagen. Okay, so in biopsy of collagenous disorders, you will keep on hearing these words. So slightly homogenized collagen, highly eosinophilic collagen. These kind of words you will hear. The elastic fibers can be normal or there can be some clumping of elastic fibers. But remember that adnexa is spared or preserved. There is perivascular lymphocytes, but there's more in the deeper dermis, in Atrophoderma. So if you look at this biopsy slide, and I've taken it from Weedon's, there is thickened collagen with uplifting of subcutis and adnexal structures. Now it's a similar concept that we see in Morphea, the upliftment of the eccrine glands. In this, instead of eccrine glands, this subcutis is getting lifted up. So what exactly has happened here is, that is how Weedon's explains it, that this is a biopsy from normal skin and this is from Atrophoderma, and they have aligned the biopsy like that so that they are at the same level. So at the same level, you can see the fibrillar collagen. Can you see thread-like thin collagen, wavy collagen? Okay, it's wavy, it's wrinkled collagen. And in this, you will have broad collagen. Look at how thick the fibers are. Can you appreciate? If you look from afar, you can actually see this thickened collagen, homogeneously stained. Okay, and look at the level of subcutis. This is the level of subcutis, na? This is the subcutis, and this is the level of subcutis here. So in normal, it is below. While in the atrophoderma, the subcutis is there. Why? Because the dermis has shrunken up because of atrophy. It has decreased in size, and that is why instead of normal epidermis, dermis, and subcutis, this is the epidermis, dermis, and subcutis, you actually get epidermis, a shrunken up atrophoderma, and a pulled up subcutis. Clear? Pulled up subcutis. Let's move forward. Now, coming to the second subtopic, sclerodermoid disorders. Okay. Now, sclerodermoid disorders are those disorders that are clinically or histologically mimickers of scleroderma. So, disorders which are not scleroderma, but they mimic scleroderma either on biopsy or clinical examination. And these include a list, and this list is not exhaustive. There are many more to that. The list includes sclerodermoid GVHD, stiff skin syndrome, GEMS syndrome, pachydermoperiostosis, pachydermodactyly, acroosteolysis, paraneoplastic pseudoscleroderma, nephrogenic systemic fibrosis, okay, sclerodema, scleromyxedema, PCD, chronic GVHD, Werner's, progeria, okay. And here we will discuss the major disorder lichen sclerosis, atrophicus, or right now as we call it as lichen sclerosis, with or without atrophy. Okay, so let's start a discussion on sclerodermoid disorders. So in lichen sclerosis, okay, what in lichen sclerosis, what exactly is happening? In epidermis, it can be hyperkeratosis with follicular plugging, or it could also be atrophy with vacuolar alteration of the basal layer and basement membrane thickening. Now remember, the thing to look for is interface dermatitis. That is what is happening. So the major action in interface dermatitis would be upper dermis. Okay. And so that is why whenever there's a problem in upper dermis, you will have some kind of alteration in the basal layer. And in interface dermatitis, we have learned about basal cell vacuolization, basal cell degeneration, colloid bodies, civet bodies, all sorts of things. You can go back and see our lecture on interface reaction pattern or tissue reaction pattern. It was the first reaction pattern that we discussed to develop an understanding of tissue reaction pattern, and you will understand lichen sclerosis. Okay. Now, there is broad subepidermal edema with homogenization of collagen and more eosinophilia. So, there's broad edema and homogenization of collagen. Collagen number 4 and 7 are increased. The cells include perivascular lymphocytes, few plasma cells, few histocytes with and without mast cells. Okay, MCs, mast cells. In 20% of the cases, there can be elastophagocytosis by macrophages. So macrophages essentially eat up the elastic fibers, leading to loss of elastic fibers. The fibers are pushed downwards and they are destroyed by the macrophages. So the elastic fibers might be lost. In bullous LS, you can see the split is below lamina densa, and this could be a good MCQ question where the split occurs in case of bullous variant of lichen sclerosis. It is below lamina densa. Let's move forward. So here you can see, if I change the color of the pen, the the inflammatory infiltrate lies in the upper dermal area, isn't it? It is just below the epidermis, composed majorly of lymphocytes. Can you see that the color of the infiltrate is very purplish, it's very basophilic, it's very blue, okay? And that exactly is what tells us that the major constituent cell is lymphocytes, okay? You have basal cell necrosis. If you look here, here is basal cell necrosis and basal layer vacuolization. Look at this. You can see those little holes at the level of basal layer. This is nothing but basal layer vacuolization. Okay, so you see these features in lichen sclerosis. Let's move forward. Here also you can easily see in later stage. Okay, let me just change the pen color. In later stage, the epidermis is atrophied. There is atrophy. There is thinning of the epidermis. So there's epidermal atrophy, but you can see a milder infiltrate just below the epidermis, composed majorly of lymphocytes. And here you can see thickening or a little bit of compaction of dermis, which is known as homogenization of dermis. The dermis looks like a single tissue. Okay, so there's homogenization of dermis in later stages of LS. Let's move forward. So the third subtopic is now other hypertrophic collagenoses. Okay, so we have discussed scleroderma and sclerodermoid disorders. Now we will discuss other hypertrophic collagenoses. And let's start our discussion with connective tissue nevi. So in connective tissue nevi, it's a hamartoma. Okay, hamartoma means normal structure, normal place, but abnormally proliferated or abnormally made. So in this connective tissue nevi, you either have collagen or elastin or glycosaminoglycans, but in very large amounts. Okay. If there's collagen in the tissue nevi, you have collagenoma, chagrin patch, fibroblastic connective tissue nevi. Okay. If it's elastin, then it is elastoma. If it is protoglycans or glycosaminoglycans, you will see nodules in Hunter syndrome. But since we are discussing only collagenous disorders, we'll keep our discussion to the collagenoma. Let's move forward. So in collagenoma, you will have epidermis that might be normal, but you can have an additional epidermal nevi. Now, what do I mean by that? See, developmental disorders usually are not alone. They have other features also. That is why you have developmental syndromes. So if one lineage is affected, the other lineage is also affected. Remember, all the cells of a tissue, they come from same source. Okay, and if there's problem in the source, the resultant tissue would be damaged. So if there's one stem cell creating the epidermis and dermis, there's one stem cell which creates a cell that controls epidermis and dermis, you can have nevi in both of these areas. So in collagenoma, we know that it's an hamartoma composed of collagen. The epidermis might be normal, or it can have an epidermal nevi. Okay. So the dermis has broad collagen bundles with haphazard arrangement. Now in normal pathology or normal biopsy, you will see storiform arrangement of collagen. Storiform means wavy, pinwheel. Okay, remember pinwheels? We used to have them in, childhood, these paper wheels. So they form arcs in normal dermal. Okay, they form arcs. But when the arrangement is haphazard, that means all collagen fibers going here, there, then that is known as haphazard arrangement, and that is a disordered collagen. Okay, haphazard arrangement means disordered collagen. You will hear this word again and again in collagenous disorders. Okay, disordered collagen. There's no increase in mucopolysaccharides. Let's move forward. So in collagenoma, you will see thick bundles. Let me change the color again. Yeah. So in collagenoma, you will have thick bundles like this. Look how thick they are, thick bundles. And you can have a square biopsy. Again, sclerosing tissues, collagenous disorders have a somewhat of a square shape, perpendicular cut biopsies. And what exactly you're seeing? You're just seeing broad eosinophilic collagen bundles in the dermis. Let's move forward. The second tissue which shows hypertrophy are the keloids. Now, keloids in Greek means crab claw. Okay, crab claw in Greek. And why it is called crab claw? Because the tissue on clinical examination looks like it is clawing around. You have heard the word claw in context of keloids. So the tissue claws and goes outside the wound margin. Okay, if this is the original wound, the keloid will look like this. Okay, so claw-like extension, and that is why it is known as keloid. In keloid, you have abundant fibrillary collagen. Abundant fibrillary collagen. And as the keloid matures, you have broad, homogeneous, brightly eosinophilic collagen bundles. Brightly eosinophilic collagen bundles in a haphazard array. Remember, in uh, hypertrophic collagen disorders, you will see haphazard arrangement of collagen. And this broad, homogeneous, brightly eosinophilic collagen bundle is known as keloidal collagen. So if you're writing about biopsy features of colloid, you have to mention colloidal collagen. You have to mention the term colloidal collagen. And you should remember that colloidal collagen is nothing but broad, homogeneous, brightly eosinophilic collagen bundles. So just remember this definition, okay? There's increased fibroblast, abundant mucopolysaccharide, and chondroitin 4-sulfate is increased, okay? So many mucopolysaccharides are increased, and one of them being chondroitin 4-sulfate. There is reduced vascularity. Telangiectasia is present below epidermis. See, whenever you're examining keloid clinically, you will see dilated blood vessels, isn't it? That's what you will see, dilated blood vessels. So when you see dilated blood vessels, you know that there are telangiectasia just below the epidermis. But there's also, in spite of having telangiectasias, the cells have hypoxia or reduced vascularity, and that is why the skin is not able to heal properly, leading to keloid formation. Keloids are nothing but a disorganized, disordered healing process of a wound. Okay. There is tongue-like advancing edge in papillary dermis. A tongue-like, a broad advancing edge. Okay. There's obliteration of the papillary reticular dermal boundary. Now remember, in papillary collagen, it is more of a vertical collagen, while in dermis, there's more of a longitudinal or horizontal collagen. And this forms a little bit of ill-defined boundary between the two. In normal biopsy, that boundary is lost in keloids. So go back and see our lecture on histology of normal dermis, and you will be able to understand what I'm saying. There is displacement and later destruction of skin appendages in colloidal tissue. So look at this now. Look at this, such a beautiful picture I've taken from Weedon's. So if you look at this segment, the middle segment, can you see how broad and highly red colored they are? Broad, homogeneously stained, bright eosinophilic collagen bundles, and they are not in story-form pattern. Okay, they have a haphazard array. They are going in different directions. Like this one is going up, this one is going sideways, longitudinally down. Okay, haphazard arrangement, brightly stained, eosinophilic collagen, keloidal collagen. Okay, so this is nothing but keloidal collagen. And if you zoom out on higher magnification, you can see these broad collagen bundles which are very eosinophilic. Okay. So, and look at the empty spaces in between. These are nothing but spaces where glycosaminoglycans were there, or the mucin or other mucin things were there, and during routine processing they are washed away and leaving behind these kind of empty spaces in between. Okay, let's move forward. Now this is a hypertrophic scar. Okay, in hypertrophic scar, you can see this is the normal dermis, and from here onwards you have the hypertrophic scar. And this hypertrophic scar is nothing but normal scar. Okay, so the tissue looks like a scar. So remember that scars, you have vertically oriented fibers. So most of the fibers could be seen vertically oriented. So much so, there's so much tightening around the blood vessels that even blood vessels, like here is a blood vessel, even the blood vessels are flattened and stretched out vertically. Okay. And if you look at the, if I just show you, I'll just click and show you the, yeah. So if you look at this, if you look at the picture, this is nothing but fibroblast. And how to recognize fibroblast? They are cells. Let me just change the color of the pen. Yeah, these are cells which are tapering at the both ends. Okay, like this, and you have a nucleus in between. Okay, so there's increased fibroblast activity, while in keloids you were not seeing much increase in fibroblast activity, you were just seeing keloidal collagen. So can you appreciate the minute differences between different types of collagen? In scar it is vertical fibrillary collagen, while in keloid it is broad eosinophilic homogeneously stained collagen, the keloidal collagen. Okay, let's move forward. The fourth is Striae Distensae or stretch marks. So Striae Distensae are nothing but scars. So they behave like scars, and on biopsy they look like scars. The epidermis is flat with loss of normal red-ridge pattern. The dermis is thin with parallel collagen bundles because that is what we see in scar. The glycosaminoglycans are increased, but the elastin fibers are reduced in Striae Distensae. Look at this biopsy, and this is not HNE, this is Verhoeven van Giesen stain, which stains majorly for, sorry. Yeah, it stains majorly for elastin. So can you see that in normal skin? Okay, this is normal skin. You can see these black fibers here. This is nothing but elastin. But when you look at stria, these fibers are lost. So can you appreciate the difference between normal and stria? The elastic fibers are lost. So there's reduced elastic fibers on special stain. Verhoeven van Giesen is special stain for elastin. Let's move forward. The fourth subtopic is atrophic collagenoses. I can understand that this PPT is getting way longer and way complicated to understand. All you have to remember is the classification of collagen disorders and the examples of them. You know the histological findings, so don't worry about it. You know the findings. You just have to remember the classification and examples. That is all. Let's move forward. So these are the examples that Weedon uses: Aplasia, Cutis, Congenita, focal dermal hypoplasia, pseudoanem, keratosis pilaris atropicans, corticosteroid atrophy, acrodermatitis chronica atropicans, restricted dermopathy. But we will not be discussing each of the disorders. We will be just discussing aplasia cutis congenita and focal dermal hypoplasia. Okay. So in aplasia cutis congenita, there is localized or generalized area of absence of skin. So if you have known about, Bart syndrome or aplasia what exactly is the name? Okay, you have aplasia, that means hypoplasia is decreased, aplasia means not there. Cutis means skin, skin is not there. Congenita means from birth, skin is not there from birth. Okay, so there's lots of generalized areas of absent skin. Most commonly, the area involved is scalp, and Frieden's classification is used to classify aplasia cutis congenita. This could be a good quiz question. Okay. The classification classifies into 9 classes. I'm not going to go into detail. Open Weedons, they have a whole table regarding Frieden's classification, so I will not discuss, not that important. The defect, that means the area where the skin is absent. You can have an ulcer or a thin membrane, or it could be bullous, or it could just have atrophic scarring. Okay. There is a ring of coarse long hair surrounding the scalp defect, and this is known as hair collar sign. Okay, this is hair collar sign, and this again could be a good question. A hair collar sign, and this area heals with cicatricial alopecia. The epidermis is absent or thin with 2 to 3 layers of flattened cells. The dermis is thin and loosely arranged connective tissue, looks roughly like a scar. The appendages are absent, rudimentary, and the subcutis is thin. What we can gather from this information is that the skin is not developed from fetal times. So if the skin is developed, the epidermis would have been much thicker, dermis would have been thicker, appendages would be there, subcutis would be okay, but everything is not properly developed. Okay, the skin is not developed. And that is the basic pathology of aplasia cutis congenita. So this image I've taken again from Weedon's, and you can see the thinness of the epidermis. Can you see how thin it is? Okay. Can you appreciate the thin epidermis? Let me just, yeah. Can you look at this thin epidermis there? And can you look at the high level of subcutis? The dermis is also thickened. There's actually complete absence at certain places. And if you look at the magnified area, the cells of the epidermis are not properly formed. The basal cells are not looking okay. They are not looking normal. The other cells, the other keratinocytes are not looking normal. The dermis has only, this kind of RBCs are collected. You don't have proper vessels. The dermis is also not properly there. So in appendages are lost. The dermis is thin and widely spaced. The bundles of collagen is just present haphazardly. That is what you see in biopsy of aplasia cutis congenita. In focal dermal hypoplasia, the other name is Gold's syndrome. Okay. In Gold's syndrome, as the name suggests, there is focal, that means localized, and hypoplasia of the dermis. So dermal hypoplasia. Okay. Just better. Now, in focal dermal hypoplasia, also known as Gold's syndrome, you have a problem in the dermis. So the epidermis is normal because it is focal dermal hypoplasia. The dermis is markedly reduced, thin, loosely arranged collagen fibers in the papillary dermis. So dermis is reduced. Dermal hypoplasia. The adipose tissue reaches up to the epidermis or around the perivascular location. So again, remember, this is a skin biopsy. You have the dermoepidermal junction, the epidermis, and the dermis. And let's show subcutis like this. So if the dermis is reduced in thickness, what exactly you will see? You will see subcutis at a higher level and a shortened, thinned out dermis. Can you see the dermis is thin now? This is the epidermis and this is subcutis. So subcutis is pulled up. Okay. So much so that sometimes it can actually reach near the epidermis. So much hypoplasia of the dermis has happened. The elastin fibers are seen in the subcutis. Now, elastin fibers, we know that majorly they're present in dermis, but if the dermis is not properly formed, some of the fibers are also seen in subcutis. Okay, so in Gold syndrome, you see elastin in subcutis, and this could be a good MCQ question. Let's move forward. So look at this structure, look at this beautiful diagram, photograph from Weedon's, and look at this adipose collection, fat collection. It is reaching up to the epidermis. This is the epidermis, and we know that you have epidermis, dermis, and subcutis, but here there is hypoplasia of dermis, so the subcutis is higher up. Let's move forward. The fifth subtopic is perforating collagenoses. Okay, in this disorder, there is extrusion. The word is extrusion. Extrusion means pushing out. Okay, if you have seen people making jalebis, so they have a pouch and there's a hole in the pouch, and from here the batter comes down into hot oil or ghee and you have jalebis. This process of pushing out things is known as extrusion. And in perforating collagenosis, you have extrusion of collagen fibers through the dermoepidermal junction into the epidermis. So let's move forward and see what it looks like. In perforating collagenosis, you have altered collagen which is eliminated from the dermis through the epidermis. The disorders include reactive perforating collagenosis, perforating verruciform collagenoma, chondrodermatitis nodularis helicis. Okay. There can be secondary elimination also. Secondary means in the primary collagenosis, you have defect in the collagen. The collagen fiber is not proper, and because of that, it gets extruded from the epidermis. While secondary elimination means that the collagen was initially normal, and now because of a pathology, it is abnormal. Okay. So that could be seen in perforating granuloma annulare, necrobacil lipoidica, in healing wounds, resolving keratoacanthomas, and even in intradermal corticosteroids injections. Okay, so somehow normal collagen becomes pathological collagen and it starts to get secreted. That is why when we are discussing reactive perforating collagenosis, you always ask history for uncontrolled diabetes or kidney issues or any other underlying comorbidities that might modify collagen leading to its extrusion. Okay, so that is what we call as perforating collagenosis. Let's move forward. So let's start with the first disorder, reactive perforating collagenosis. Okay. In early stage, you have acanthosis and basophilic collagen in the papillary dermis. So it is still in the dermis, but in the upper layers, not there yet in the epidermis. In the later stages, you have a cup-shaped epidermal depression filled with a plug of parakeratotic keratin, some collagen and inflammatory debris with no basal lamine. So what exactly is happening? This is the dermoepidermal junction, epidermis. Okay. In reactive perforating collagenoses, you have a crater, a pit, a pit. And from this pit, altered collagen gets pushed out. That is what is happening. So reactive because it's a reaction to our altered collagen. Perforating because collagen goes out from the holes, from the perforations, and collagenosis because collagen disorder. Okay. The underlying epidermis has thin with fine slits through which basophilic collagen fibers go in vertical orientation are extruded. Now remember, collagen is mostly horizontal or in a story-form pattern in dermis, normal collagen. Okay. If it becomes vertical, that means something is wrong. And if you look at this word, basophilic, remember previously wherever we have discussed collagen, we have labeled it as eosinophilic, isn't it? Eosinophilic means red, but basophilic means blue or violet or purple or dark blue. So in reactive perforating collagenosis, you will see blue colored collagen coming through the epidermis from the floor of a crater. Okay. In 40% of cases, follicles can be involved. Let's move forward. So this is a very nice picture from Weedon's. No, not from Weedon's. I've taken it this from an article. So can you see this cup-shaped crater? And it is filled with dark blue material, and that is nothing but collection of collagen which is extruded out. And if I remove this line, you can actually see this vertical orientation of collagen fibers. Can you see what? Can you see here? Lines, vertical lines, okay? Longitudinal lines going inside the crater. Let's magnify and see what are we meant to see. So now you can easily see the crater, you can see the collagen fibers, darkly staining, dark blue collagen fibers, highly basophilic collagen fibers going here. Here you can see the normal collagen which is eosinophilic, normally pink stain, but now it has become blue or very dark blue going inside the crater. So if you look closely, and this we have used a special Mason's trichome stain, and here you can see basophilic or blue shaped, not exactly basophilic, but blue colored collagen going inside the epidermis. This is normal keratinocytes, okay, in epidermis. So this area whole is epidermis. This is from the dermis, and the fibers, the collagen fibers are going inside the epidermis in reactive perforating collagenosis. Let's move forward. Okay. Yes. So before starting elastin disorders, what I'm going to do is I'm going to take a short break because we have already crossed 1 hour and we have discussed collagenous disorders in quite a detail. We have looked at the slide photographs and we'll quickly take a short break. I'll drink some water, take some rest and continue recording the video, and we'll upload them in 2 parts because it's getting too long. So we'll upload them into 2 parts but together, and we'll just take a 5 minutes hiatus and come back and discuss quickly elastin disorders. Okay, let's take a short break.